teachers and my colleagues. First of all, I thank for the organizers and Dr. Hartha Madam for giving the opportunity. This is my native place, Guntur, to present this lecture. And before going, now next 2 to 3 decades is image guided interventions will rule over rather than angiographic interventions. And as Dr. Ravikant beautifully described, if you take the best resolution instrument will give the best results. So it is everybody knows that OCT do the better in all complex lesions. So debate is immaturity, but knowing the strengths and weaknesses of each application, then you apply in appropriate situation is the maturity or wisdom. So with this background words, just I want to describe IVUS, how it is used in the special clinical situations where it scores over the OCT data. So this is the agenda. First I will tell the basics of some images and morphology of reading the atherosclerotic lesions. And second one is how the IVUS scores of the OCT whenever there is a chronic kidney disease. Of course, in this situation, even though IVUS do better, sometimes with saline contrast OCT nowadays giving, it is feasible, that's all. It is not universally. As we know, the isoosmolar contrast will displace the blood and giving the correct resolution. Water can't displace, but still it is feasible. It is some studies are doing from Ahmedabad, I forgot that operator name, and he did almost some 100 cases, and it is feasible only in the 60 to 70% of cases only it is feasible. That is the answer for Dr. Srinivas's question. And the second one is in left main, especially iodosteal lesions, definitely IVUS scores over the OCT, as OCT can't displace the contrast at the site of the ostium if you want to know the morphology. And third important is in CTO, always IVUS has a role. Only OCT role is optimization of the stenting. And so these are some of the basics where you can see eco-white, the fatty clots, and fibrous clots is eco-bright, and calcium is milky white appearance. And it's not moving, can okay, here it is. So it is coming late actually. So these are the basic images, how you can see the 60 megahertz actually almost it gives almost near resolution of the OCT. If you carefully see the intima, the media will see as a eco-wide and eco-bright intima as well as the adventitia. You know, concentric clock means intima-medial thickening will occur, whereas eccentric means more thickening on one side. And fibrotic, as I told, it is a eco-bright, and milky white, it is a calcium in the eco image. So this is normal vessel you can see, and then this is the concentric block, this is the eccentric block, and this is the soft block. Soft block is a mixture of the fatty plus fibers. This is a fibrotic block, eco-bright. And this is the calcium, you can carefully see there's a milky white in the eco appearance. So these are the complex, some of the lesions which will appear. Dissection you will see as a breach in the intima, whereas the thrombus in the lumen you can see the echoic shadowing, moving mobile shadowing. Whereas the hematoma you can see the breach in the intima followed by echo-wide space in the media, which is a larger one. So this is the dissection you can carefully appreciate. And this is the thrombus, already I told. And this is the stent. This most important is whenever optimization of the stent, two important parameters are one is expansion, second is opposition. Expansion means the stent instead of circular, it will have protiscary features, especially the calcium lesions and fibrotic lesions. These are things happen. So this is a nidus for the stent thrombosis as well as restenosis in the long term. Whereas the opposition is there is a space between the abdominal surface of the vessel wall and the stent. So if it is improperly opposed, malopposed, that is again a nidus for the restenosis. So these are the appearance of the Nana position, Mala position, where you have to see the, especially if you take undersized stents and undersized balloon expansion, this will happen. So you have to take 1.5 or one quarter higher size the balloon in the posterior dilatation, and you can rectify this expansion. Another important is low contrast angioplasty, zero contrast. You can do by means of integrated IVAS with a co-registration, where exactly the site of lesion, the plaque morphology you can assess by means of this software. And then the most important in the IVAS in the left main, I want to be where its force of the OCT is iotosteal lesions. So the benefit, especially image guided left main interventions, give the optimal result with low miss rates, and especially in the Excel trial which was shown that angioplasty is almost superior or non-inferior to bypass surgery. The usage of intravascular imaging is almost very high, 52%. So these are some of the data where showing the minimal stent area of intravascular ultrasound should be more than 8.5. Suppose if it is less, that is 4.4 to 8.7, almost 30-day mortality as well as the occlusion of the other branch disease and stent deformation, there are very high if we won't use the image. And of course, this is the benefits of intravascular left main. It is almost showing it reduces the stent thrombosis and improves the mortality, because the left main, as we know, it won't give time. So always you have to aim at the perfect result if you do the left main interventions. And then the borderline assessment, borderline lesion assessment is also important, especially with the IVAS. As we know, here I want to do very important is iotosteal lesions, where you can put the transducer exactly at the ostium, and you can know the osteal left main, where the OCT can't do this one. Here the IVAS scores or the OCT, you can assess exactly the minimal luminal area and the plaque morphology, and you can have to protrude the stent in the iliocranial. There is the best view to cover the ostium and slightly protrusion 10 millimeters into the sinus. So this is how you can optimize the lesions in left main angioplasty. And this is one of the beautiful diagram from the series of the BARC, the left main interventions, where you have to disengage the guiding catheter to remain the left main, especially ostium. And of course, is important in understanding the plaque morphology. Especially the calcium is there, you have to use the aggressive plaque modifying devices and optimize the stent implantation. The main it is 8 millimeters, and in the PLN point of control is 7 millimeters, and LAD 6. This is the minimum stent area whenever you do the two stent strands in the left main, so that the long-term results will be good. And this is one of the case review. A 15-year-old patient, underwent LAD angioplasty 300 years. This patient admitted again in the hospital, new symptoms, unsuccessful attempt to open the calcified lesion in the proximal circumflex with a small balloon, and patient was referred for the rotablation. And in rotation ectotomy, you can cross over the rotor with a block with a modified 1.5, but with a smooth channel was created in the proximal circumflex, so that the protruding, the uncrossable lesion becomes a crossable after doing the aggressive rotablation. And of course, then followed by pre-dilatation with 2.5 NC below. After pre-dilatation, second guide was replaced in the LAD. And this is the pre-PCI run in the circumflex. You can see after debridement of the material, calcium material, and this is the left main measurement by means of this one, and then the stent was placed 3 to 22 in the mid circumflex first. The next 3.5 to 16 was implanted in the left main, the direction of the LAD covering the ostium of the circumflex. Then this is followed by a special wire was selected to cross the cell of the stent entering the circumflex, and ultimately the balloon was inflated to open the circumflex ostium. And you put the T-tap technique, you covered the circumflex ostium after adequate rotablation of the calcium in the circumflex to get a good result. So then followed by proximal kissing and followed by part ultimately to give the good result. These are the steps which you do whenever you want to do the provisional with T-tap. This is the final result. With IVAS, you get a good area of left main, almost to the 8 millimeters, square millimeters. Then the most important CTO, how the IVS is useful, especially three important steps is important. First one is a proximal cap puncture. This is the patient, he presents with infrared MI with a lady total occlusion and RCA total occlusion, that is thrombotic. An angioplasty primary was done to right Kaparadhi to LV function. So this is the one. You can see the LAD almost is the stumbless occlusion where you are able to identify the cap. And as if LAD is continuing as diagonal, you can see visualize it. And so this is you can see the proximal cap between the 6 o'clock position and 9 o'clock position, you can appreciate. And then by means of the crusade catheter, which is a dual lumen catheter, you put the wire in the diagonal and then with the over the port, that is the central lumen, you can pass the dia second as well as the total occlusion we directly have taken to conserve the material also. And then with the help of this one, you puncture exactly, you can see, you can appreciate this one, you can appreciate the wire shot, and then exactly 2 lumen to 2 lumen, you can identify the revascularize the LED. So at this, the IVS always goes whenever the stumbless occlusions in the CTO. And then second case also, it is almost a stumbless type of occlusion. The patient with the angina with a single vessel disease and attempted PLN previously failed. And then this is the one by means of retrograde wire we keep as a wire marker, and then with the help of real-time IVS. For real-time IVS, 8 French guiding catheter you have to take and then put the wire in the side branch and keep the IVS exactly at that one with the fine cross help and dia second penetrate the cap, and ultimately we revascularize the LED and with a good result. Then second important is IVS guided reverse cart. This is also important, especially whenever you are doing a complex high-grade CTO. This is important. This patient is a diabetic hypertensive, already underwent angioplasty LAD, and the RCA CTO was index lesion. So this is a dual lumen dual angiogram which was showing a RCA mid-segment CTO, and we have taken with the help of the boat stay and then the hard wire, we cross the CTO, but still the wire is in the subintima, so we do not want to take the chance. Antegrade prepared, then retrograde, we put the wire and then ultimately study. You can see the retrograde we cross, and ultimately by means of the reverse cart, which means the antegrade balloon we dilated, retrograde wire we have used it, and these IVS, both wires you can see as a you can see they are in the 2 lumen. Once from the subintima to intima it came, and once we confirm by means of IVS with the reverse cart, then externalize the wire and revascularize the RC. So this is an entity where IVS definitely has a role, especially IVS with reverse cart we can do. And another important, this is a new concept by Okamura. Actually, he 3D wiring of CTO, especially when you are wiring the CTO. Now the terminology was changed, intra-block or extra-block, rather than the intima subintima and CTO terminology. This is the one he coined. So this real ridiculous time spending should be there. And usually in the IVS, the shaft will be seen as a dot with a backscatter, whereas the tip will be seen as a thin line with a backscatter. So this is the one, usually this applicable 3D application, the 3D wiring in the mid-segment of right artery last one. It will be there, and of course here you keep the IVS in the intra-block, and then you keep the second wire. Depending on second wire in the space that is intima, you have to correlate in the brain both sagittal coronary planes of angio and the axial sections of the IVS. So this is the one. Whenever this is at the tip, you can see the tip of the wire. Then as the wire you are entering to the distal cap into the 2 lumen, almost this is the IVS is in the false plane. This is in the inside the block. By means of counterclockwise and clockwise rotation, the tip direction, tip distance to the 2 lumen you can identify, and ultimately you can enter to the 2 lumen, which is a collapsed lumen. Remember, this is a 2 lumen which is a collapsed one. This is the wire. By means of counterclockwise, depending upon the orientation, or clockwise, you can enter the lumen, whichever nearer. So with this, I will end this section. So ultimately, if you have OCT enlarged by virtue of its high resolution, it is always better and best. But exceptional situations, you have to use the intravascular ultrasound. And second is the cost effective. And another important thing, where OCT is very sleek. Sometimes in calcific lesions you can't push. We have seen so many times, in spite of clock modification, depending on ambulated calcific lesions, you can't do the OCT. In that way, OCT is unable to navigate, then we have to take the IVUS. Definitely IVUS will pass through after a lesion modification. So these are the situations. Whenever the contrast is a limitation, take IVUS is better, because still it is a saline contrast OCT is still in the developing phase, not established one like a contrast OCT. The second important is the iodoarterial left main. Always IVUS is better. OCT can't displace because it needs a lot of forceful injection to displace the blood. So iodoarterial lesions limitation. Third one, CTO. Yes, IVUS plays important role for for guidance actually to your hardware and your wires you can navigate. And of course, fourth one, where the OCT, it can't negotiate across the calcific angulated lesions, then because it has sleekness, we have seen so many times in the practical, then IVUS, after adequate block modification, you can negotiate and give the optimal image. Thank you.
And most speakers enlightened us how important for the future coronary interventions, how this co-registration of both with IVUS and OCT is the key factor, not by just mere angiography, in knowing the future results and days after the interventions. So any few questions you can take, one or a couple of questions you can take.
Ravikant, you can come on to the dais.
Just to add, definitely there are few things which are tough with OCT. I've seen practically if you try to do 5 times in a patient, the 5th time the catheter will be broken. It is very tough to negotiate it because the pushability is not there and that stiffness is not there in the catheter end. So what I do is usually, and there is nothing like G here. G people are using with extremely less. You can only do one run and then you will end up with not doing the second run. So that is why if you are intended to do 4 or 5 runs, you are planning for 4 or 5 runs in a bifurcation lesion or something. So try to do it with one is 7 French catheter anyway will be there. Another thing is you should use a guideliner to deliver this OCT. And as Dr. Kaparadhi was saying, if it is a calcified angulated lesion and very pinhole kind of situation, unless you dilate it properly, you cannot negotiate the OCT catheter in. Again, the guideliner would help in delivering the OCT catheter. And I would put it this way, I would try combining both. For example, aorta ostial lesions. Aorta ostial lesions, I am in left main lesions, for example, left main bifurcation you are doing. So there is an ostial lesion as well as distal left main and everywhere. So if you are trying to do along only IVUS, you would be not getting benefit of an OCT. But if you are trying to do only OCT, you would end up not doing well at the ostial. So combining the IVUS and OCT in this kind of situations where you will have an advantage would also help but I don't know the logistics how it would be here. But in present situation, a lot of people are affording this imaging if you explain them well. So combining the IVUS with the OCT would be one more thing rather than fighting against each other. I think combining both in particular situations. And saline contrast, I have given total saline in without a contrast at all in 5 cases till now, and I had a good imaging result. And as you were telling, the problem would be only where you have a large vessel. Large vessel, I couldn't clear the blood properly. But if it is 2.5 and 3 mm vessels, it would happen. And I was forced to do for the first time. Actually, it was in a patient where the creatinine was 4.5 and there was a restenosis happened within 6 months and it was 5 stents inside. So I tried a saline contrast in this patient and I succeeded in imaging well. So that's how I started doing saline as a contrast, but I am not doing it regularly. It is only in patients where this kind of situation happens.
I want to add 2 points. I also tried saline, but the image is suboptimal. The decision making is difficult. And second important thing, if you want cost effectiveness, IVS is always better. You can use infinite times actually. G catheter.
Radhikant, in acute coronary syndrome, I was went to differ the stenting depending on the morphology with OCT. Went to differ the stenting by OCT morphology in imaging in acute coronary syndrome.
One thing, I have done only one case in acute coronary syndrome, OCT. As far as possible, I try to come out as early as possible without doing anything. So, in that particular case, there was a plaque erosion and lot of thrombus, and we could clear it and then put a stent properly. But my intention of doing it in that particular patient is he is an youngster, around 25-year-old. So I thought if there is something only thrombus with no clot, I would come out without stenting. That was my intention. That's why I have done that particular case. But in any ACS, I try to minimize imaging as far as possible. I don't know the take of others.
But Simon, for you, the important one is, as we know, the ACS is caused by rupture, erosion, and of course scad and nodule. In a small percentage of young patients where haziness will be seen on the angio, if you do the OCT for those patients, just plaque erosion, that will plaque erosion means you won't see the rupture, whatever the thing, just only some adherent small white clot will be there. So in those patients, you can confidently live without any stenting, and definitely long-term results will be very good. And vessel has its own repair in the natural mechanisms. Only thing you have to give is some 2B3A blockers along with an aggressive prosuperil, so that the patient long-term MACE rates will also less.
Radhikant, last question. For the landing zone of the stent, usually you are shown in the slide less than 50% of the lipid pool and less than 50% of the plaque burden. But usually people say normal to normal. So do you practically follow the landing with less than 50% of the lipid pool and?
No. Actually, as far as possible, normal. But you can have a diffuse disease. Then you need to search for the landing zone. There you end up this way. So a lot of times I do like this, in especially diffuse disease. See, for example, nowadays we are putting 2.5 to 48 stents, and you have a lesion down as well, extending into distality and kind of thing. So in this case, I am doing that such a way, less than 50%.
I want to answer Dr. Simon regarding your question. Most important, as Dr. Radhikant told, healthy is okay. But suppose in diffuse disease, whenever you are landing, what he told is correct, but only vulnerable block you see. Whenever you are landing, if vulnerable block don't land in that one, even though 50% block, 50% normal is there. Suppose in the fibrous blocks, yes, you can land. Okay, that is the one. Vulnerable block don't land there. Again, it may produce itself again acute condition.
Okay, you have to follow normal to normal in angiogram based angioplasty. 50% 45 is inverse. So you cannot compare both.
When it comes to see, affordability is not only for the patient, for the doctor also. So in conclusion, if you can afford only one, which image you suggest?
I prefer OCT because I was well trained in OCT and doing OCT more.
I will also suggest OCT only. If you want, ideally for a doctor, if you want a good thing you have to do, only OCT. Except these exceptional situations where you have to use IVS. Because you can't take a decision with the natural black and white movies same. Eastman color and colorful movies different. Everybody knows.
I thank you, moderators and chairpersons. We will have the Dr. I.V. Prasad elaboration next, but I request the chairpersons and moderators to remain seated for Professor Dr. Vijay Bang, who will be speaking to us virtually. As you all know, I have his CV here. It's a pretty long CV, so I'll quickly read up. Meanwhile, the connection is made. I request the chairpersons